Good afternoon. My name is Nicole Clark, and I'm the Associate Director of Patient Advocacy for the Immune Deficiency Foundation. Thank you for joining us. Before we start today's session, I'd like to go over a few reminders. Please remember that each patient's treatment and condition is unique. The content that is presented in this session should not be substituted for professional medical advice. In all cases, patients and caregivers should consult their healthcare providers. Also remember that where you are on your journey of living with primary immune deficiency may differ from that of others in the community. The severity of PI can vary, and we ask that you're supportive and respectful of one another as fellow members of the IDF community. Questions will be answered at the end of the presenter's talk, so please submit your questions in the question box located at the bottom of your screen. The presenter will answer as many questions as possible during the session time. Now, it is my pleasure to welcome you to our breakout session, GI Issues and PI. This session will be presented by Dr. Sarah Glover. Dr. Glover began her research career by working in the laboratory of Dr. Michael Gelb at the University of Washington. She attended medical school at the Chicago College of Osteopathic Medicine and completed her residency and fellowship training at the University of Illinois at Chicago. She was an assistant professor of medicine and bioengineering at the University of Illinois at Chicago from 2004 until 2010. From 2011 to 2019, she served on the faculty at the University of Florida. Since January 2019, she has been the Division Chief for Digestive Diseases and Nutrition at the University of Mississippi Medical Center. It is my pleasure to present Dr. Sarah Glover.
All right. Well, thank you all for having me. I really appreciate it. And my usual disclaimer is that there's always some IT issue that stalks me. So hopefully that won't happen today. So I do have a couple of disclosures. I have been involved with pharma in various research capacities. I've also served on a number of speakers bureaus, and I am currently serving on a data safety monitoring board for Janssen. I wanted to talk about a number of things related to primary immune deficiency. We're going to go a little bit over gut immunology, some infectious GI diseases, talk about inflammatory GI disease, nodular lymphoid hyperplasia, some very specific liver and biliary GI diseases, and then we'll talk a little bit about cancer and neoplasia and some diet and nutrition things. So this is a pretty simple diagram of the gut barrier, but it's really important to understand when you're thinking about primary immune deficiency. So in the normal gut, you have the microbiota, which are on top. You have the epithelial layer, and you have a lot of different cell types that are in the lamina propria. And dendritic cells are important because they actually communicate with what's going on in the lumen of the GI tract. And all of these cells are really relevant to primary immune deficiency. In the small intestine, there are a variety of cells that are extremely important to primary immune deficiency in patients with primary immune deficiency. Intraepithelial lymphocytes are important for the gut barrier. You have Peyer's patches, which are in the small intestine. They can contain T and B cells. You have M cells, which are important communicators with Peyer's patches. And you have Peyer's patches that communicate with mesenteric lymph nodes. There's a lot of macrophages in the lamina propria as well. I'm sure you've been hearing a lot about macrophages on the news in reference to COVID. They seem to be an important cell type that we're thinking a lot about. Primary immunodeficiencies are varied. There are probably at least more than 350. I made this slide 2 years ago, so I think there's a few more that I need to add, but there's more than 350. And probably about a third of patients with primary immune deficiencies have some kind of GI complaint. GI symptoms and complications for primary immune deficiencies can be varied. They can include diarrhea, they can include inflammatory diseases, problems with the liver or the biliary tract. There can be some oncology problems, there can be malabsorption of various sorts. And sometimes treatment with IgG doesn't fix that. So there may be some other things that we have to do to address that. I put this slide in here because I think it's a nice descriptor slide for how varied the pathology can be. You can see a variety of pathological findings on histopathology in patients with CVID or hypogammaglobulinemia. IgA deficiency, you can be normal or you can have more celiac-like findings. In chronic granulomatous disease, by definition, you tend to see more granulomatous findings. But this is basically in here more for your reference. I like this slide. So moving on to other things that can affect the GI tract, probably the most common thing that we think about with PIADDs is infectious diarrhea. And these infections can vary depending on where the defect is. So if you have defects in humoral immunity or antibody production, so B cell problems, you do have an increased risk of some bacterial and viral infections. Defects in T cells, increased risk of viral and fungal infections. Defects in both T and B cells, you can have increased risk of bacterial, viral, or fungal infections. And then impaired phagocytosis, like we see in chronic granulomatous disease, you can see both issues with bacterial and fungal infection. And in my practice, I've seen all of these things manifest in different ways. So what do these infections look like? So in CVID, the bacteria tend to be things that we think about. And of course, I told you there's going to be some IT thing. There's some pop-up that came up. In CVID, it tends to be Campylobacter or Salmonella H. pylori. What's interesting about H. pylori is it tends to vary in regions. In Florida, I would say it was far less. We saw like 20% or less H. pylori. In Mississippi, I'm seeing a lot more H. pylori infections, which is sort of interesting. CMV, norovirus, Candida infections, different parasites, Cryptosporidium, Giardia, selective IgA deficiency. You can see parasites, you can see Giardia, XLA or hypogammaglobulinemia. Again, the more common enteric bacteria, Salmonella, Campylobacter, Shigella. Rotavirus can be problematic, Coxsackie virus, echoviruses, and then the parasites, Cryptosporidium and Giardia again. There are some more newer ways for diagnosing these things. I tend now, probably 10 years ago, I was doing a lot of oven parasites in stool cultures, and now there are these nice GI pathogen panels where you can look for 21 different things. Because we are in the era of the COVID-19 pandemic, I mentioned SARS-CoV-2. I think anybody who comes in with diarrhea and nausea, vomiting, we've got to think about SARS-CoV-2, and we do need to test for that. In our prospective COVID immunology study at the University of Mississippi, we found that roughly 50% of the saliva samples and more than 50% of the stool samples were positive for virus. It remains to be told how much of that is live virus and how much of that is causing trouble in the GI tract, but it's definitely something you've got to think about in this era. Other things that we have to think about in general, treatment is guided by the results of laboratory testing. So it depends on what you've got, how we decide to treatment. Some of the treatments may need to be longer. We included two of the areas where you kind of got to be a little more aggressive in treatment: Candida esophagitis and CMV colitis. Both of these are kind of ugly looking. These are things that actually I do see fairly frequently, both in my inflammatory bowel disease population and in my primary and secondary immunodeficiency folks. And it can be difficult. I have one gentleman I'm treating right now for CMV that has been pretty refractory to a lot of treatment. So sometimes we've got to work together. The immunologist, the infectious disease doctor, and the GI doctor often have to work together to treat this. So moving on to another topic, autoinflammation and autoimmunity kind of go hand in hand with primary immune deficiencies. And sometimes this is the presenting illness. I have a gentleman right now that I'm seeing who really, the autoimmunity is more of his presenting illness. So how does this happen? You basically have immune dysregulation, and so you get an inappropriate immune response. And this leads to autoimmunity or autoinflammation or uncontrolled inflammation. And kind of examples that we see in primary immune deficiency disorders are celiac or celiac-like disease, inflammatory bowel disease, pernicious anemia, and gastritis, and autoimmune liver disease. So let's talk about celiac disease. This is a pretty hot topic and it's important to think about. So this is really an autoimmune disease due to inappropriate immune response to gluten. Endoscopy often shows inflammation and villus blunting in the first part of the small intestine. I would caution you that this is not always true, that this is not 100%. And there was a really nice article published a couple of years ago in Gastroenterology that showed that sometimes it can be other parts of the GI tract. So if your physician is really suspicious, they may need to do additional imaging. It can be asymptomatic, but may present with malabsorption, weight loss, diarrhea, anemia, bloating, abdominal pain. And there is an increased risk of overlapping celiac disease and CVID and selective IgA deficiencies. All of my inflammatory bowel disease patients do get tested for celiac. But if you are IgA or IgG deficient, sometimes there can be challenges. So what do we do in selective IgA deficiency? And it can, like I said, be more difficult to diagnose these people. You can check at TTG, IgG. It's not always perfect. There is a 5 to 10 fold increased risk compared to other studies. It can be as high as 35%. And really the treatment is going to be a gluten-free diet. I do see in one individual who's like this, who has IgA deficiency and has celiac disease, and it took a while to figure out how to monitor that individual and how to control their disease. But ultimately, it was a really strict gluten-free diet. Sometimes in certain types of celiac disease, you do need to use a little bit of immunomodulation, but that's a little bit outside the scope of this talk to discuss. In CVID, diagnosis is usually made by an endoscopic biopsy in patients with symptoms. You often want to do genetic testing. That's not going to be changed by underlying CVID. So HLA-DQ2 and DQ8, which can be very predictive, especially if both of them are positive. And if the gluten, sometimes the gluten-free diet doesn't work and you may need some steroids or some immune modulators. I have an ascertainment bias in my practice, so sometimes we'll see patients that do require that. And with really severe disease, you can get bad malabsorption and nutrient deficiencies. So it's something you definitely have to think about and look at. Again, I just included this just to give you an idea, an overview of some of the things that you can see on pathology. This is actually a nice literature review of all of the things. It's fairly recent, but it's helpful for all of you to have this information. We talked about esophagitis. We talked about H. pylori. We talked about different gastritis that you can see. Duodenitis is not uncommon. Villus atrophy, which you can see in celiac disease and celiac-like disease. We talked about these innate lymphocyte or these IELs that can be present. Apoptosis. So I want to bring up apoptosis because I've seen this in a number of early onset inflammatory bowel disease and in patients who have primary immunodeficiency. So this can come back on your report, and that basically means there's more cell death. And it's usually in the epithelial layer. And when that happens, it's oftentimes just, it can cause gut epithelial dysfunction or gut barrier dysfunction. So inflammatory bowel disease and IBD-like disease. So this is my area of expertise. It can be a sign of underlying primary immune deficiency. Some of the types of primary immune deficiency, especially those with antibody defects or chronic granulomatous disease, are an increased risk compared to other immunocompromised patients. So selective IgA deficiency can be up to 5 times the amount. And there's There's other times where it doesn't get better with traditional IBD medicines. I sometimes have to get very creative. I find that patients that I treat with primary immune deficiencies oftentimes don't respond very well to anti-TNF, but respond to other immunomodulating drugs and some of the newer drugs on the market. It's very much individualized. This just gives you a picture of what the mucosa can look like in primary immune deficiency. This is small intestine, and this is an ulcer here on the right. You can see, obviously with CVID, you can see an IBD-like illness in the small and large bowel. I would say more frequently in my practice, I see the small bowel being involved, but that doesn't mean that it's not true. It can't involve the large bowel. It's sometimes difficult on endoscopy because it can be indistinguishable, and biopsies on endoscopy can differentiate CVID from typical IBD. And that in the previous slide, I'd kind of given you some examples of that. You're going to treat the same as IBD, but as I mentioned before, some of the medications may not work as well. And so it has to be a very individualized treatment plan, which I think Nicole brought up at the very beginning. These are just some histological examples of what IBD can look like. There tends to be less inflammatory infiltrate. There's a granuloma here. And you do see fewer plasma cells around typically in CVID-related IBD. Another topic that comes up frequently, we don't see this often, but it is important to talk about this in a GI-related primary immune deficiency talk, is nodular lymphoid hyperplasia. It is a benign condition where there's multiple small nodules within the GI tract. It more commonly affects the small intestine, but can also be seen in other parts of the GI tract. It's typically an incidental finding on endoscopy. It can be associated with antibody deficiency syndromes, including XLA. And it's occasionally associated with abdominal pain, diarrhea, bleeding, and intussusception. And intussusception is where the bowel gets stuck on itself because of this, and malabsorption and intestinal obstruction. Here's a picture just so you can see. On the left is an endoscopy picture, and on the right is a histological picture of what it looks like. So liver and biliary disease. So again, this is something that I do see frequently in my practice because of I treat a lot of inflammatory bowel disease. It can be common. This is a reference to give you an idea. So out of 147 patients, about 24% of them had it. You can see an enlarged liver, which is hepatomegaly. You can also see sclerosing cholangitis. So what sclerosing cholangitis is it's basically a scarring of the ducts of the liver. So you can turn yellow, your liver function test can go up, your alkaline phosphatase can go up. I have some evolving thoughts about sclerosing cholangitis, and this is Sarah Glover with her research hat on. At our institution, we're starting to do more spyglass, which means you can put a camera into the ducts and you can actually take biopsies. And we've been finding a number of IgG4 related cholangiopathies, and those are treated a little bit differently. So it is definitely something to think about in individuals that you think you might be able to change treatment by doing that. So CVID is definitely a disease where there's increased risk of autoimmune, liver disease, primary biliary cirrhosis, which is now considered primary biliary cholangitis, autoimmune hepatitis. These are primarily, so PSC, or primary sclerosing cholangitis, is made primarily via imaging, an MRCP or an ERCP, which shows you the ducts. Autoimmune liver disease and primary biliary cholangitis are primarily made via a biopsy of the liver. CGG does increase your risk of liver abscess, and those can be bacterial, Pseudomonas, or Staph aureus. They can also get chronic hepatitis. Hyper IgM can lead to liver disease, and it's suspected to be associated with cryptosporidium infection. We talked about the last part of that. So what are some other considerations for cancer? So PSC, as I mentioned on the previous slide, does increase your risk of cholangiocarcinoma. So if you have PSC, it's really important to get yearly imaging of your liver ducts or an MRCP. We will also check a CA19-9 every year. If those are abnormal, you do need to proceed with an ERCP. And if your physician feels that it's necessary, perhaps a spyglass. So what are some other considerations? For cancer, CVID is associated with chronic inflammation of the stomach or gastritis, pernicious anemia. So that can increase your risk of gastric adenocarcinoma. There's also an increased risk of lymphoma, typically non-Hodgkin's lymphoma. And we do recommend an AGD at the time of diagnosis and possibly routinely. It depends on what you find. Most patients, we do H. pylori testing standard on a gastric biopsy. So almost every pathologist in the US will do an H. pylori stain on biopsies. It's pretty much standard of care. Hyper IgM, there's an increased risk of pancreatic, liver, and biliary malignancies. If you come to see me and you have a CVID or another primary immune deficiency, I'm going to make sure you get a good set of cross-sectional imaging. These non-contrasted imaging studies are not helpful, and it's really important to get one good set of imaging. So if you've seen me in clinic or you've heard me talk, you know I will preach that. It is important to keep an eye on liver function tests, including GGT, there is a risk of, with IgA deficiencies, somewhat of an increased risk for gastrointestinal malignancies. And I should remind everyone that inflammation and malignancy are linked. So if you've got a lot of inflammation in your gut, your malignancy risk is higher. And that's why we're so keen on treating inflammatory conditions in the GI tract. Moving on to another topic. Malnutrition and failure to thrive are common in primary immunodeficiencies. Many of the patients that come through my clinic have nutrient deficiencies, and many have struggled with malnutrition. It can be up to half of CVID patients, and there's a lot of different micronutrient and vitamin deficiencies that happen. Iron deficiency is extraordinarily common. Folic acid deficiency, zinc, selenium, magnesium, calcium, and vitamin D. I don't think I put this in here, but I remind all of my inflammatory bowel disease patients and all of my PIDD patients to please get a DEXA scan. We see a ton of bone loss related to inflammation and nutrient deficiencies, so please get that done. Vitamin A, B12, E, K, not uncommon to see those. There are protein-losing enteropathies that can happen, and we usually check for stool alpha-1 antitrypsin. Fecal elastase is something we check frequently because of pancreatic exocrine insufficiency. That can be primary and that can be secondary. And I do see that quite frequently. That can be addressed with pancreatic enzyme supplements. So in thinking about micronutrients, we talk a lot about diet. If you're gluten sensitive, a gluten-free diet is not unreasonable. It doesn't mean you shouldn't get grains, but it is something that you should definitely be aware of. Even if you don't have celiac disease, sometimes gluten-free diets are helpful. There was an American Journal of Gastroenterology paper that came out a number of years ago that suggested that patients with HLA-DR mutations could have an increased risk of gluten sensitivity. So it's something to think about. It's really an individualized approach. I know sometimes that's difficult. I do recommend that patients keep food diet, and there are really no specific dietary studies. And we'll talk a little bit in a slide or two about the specific carbohydrate diet. I wanted to bring up food allergy testing. Actually, one of my allergy immunology colleagues encouraged me to bring this up because it's frequently a question that I get. So the immunocap RAS testing is really the most specific. The gold standard is still the food challenge, which is incredibly difficult to do. Skin prick testing can be helpful sometimes for IgE-mediated food allergy. Patch testing is useful for delayed hypersensitivity. We don't tend to do that much, but it's still helpful sometimes. We are seeing more and more testing for IgG related food allergy. This can be challenging because it can just reflect what you're eating. And for patients on IVIG, it sometimes reflects the donor pool, what you're getting. And we really don't know enough about T-cell mediated food intolerance. It's something that's still a big question mark, and we'd probably like to know more about. So returning back to the specific carbohydrate diet, I like this diet because it's actually fairly well balanced. It's a diet that the Crohn's and Colitis Foundation of America currently has in a clinical trial for Crohn's disease. So they're looking at that compared to the Mediterranean diet. That trial has not completed enrollment, but it is fairly balanced. It removes a lot of grains, dairy products, and simple sugars. And it does tend to be effective. I like it again because it is fairly well balanced and people don't get nutritionally deficient on this diet. Some other considerations to bring up are bile acid loss. This can happen, especially if you've lost some of your bowel. If you've had a cholecystectomy, if you've had an ileal resection, you can have more bile loss, and bile acid binders like cholestyramine can be helpful if you're having diarrhea in that setting. I realize there's a typo here that should say lactase deficiency and sucrase deficiency. There is more specific testing for sucrase deficiency. One of my GI colleagues actually diagnosed one of my PIDD patients that she inherited after I left Florida with this. So I feel like it's important to bring up, but it can be helpful. And there are agents that you can use to address this in improving your diet. These can be either primary or secondary. We see a lot of secondary lactase and sucrase deficiency just because of gut barrier dysfunction, and those enzymes tend to get impacted. Mast cell activation, we could spend an entire lecture talking about this. Largely in primary immune deficiencies, this is secondary. It doesn't mean that you have systemic mastocytosis. I'm trying to think, I don't have any patients in my particular practice that have systemic mastocytosis and overlapping PIDD. Not that it can't happen. I do have a fair number of hereditary alpha tryptophanemia folks that also have, mast cell activation, and that's more of a primary cause for mast cell activation, but it has other immunological issues associated with it. The last thing I want to talk about is about the microbiota. This is a favorite question that I get in clinic, so I decided to include this. So typically the bugs in your colon are commensals, and they get along great with what's going on in your GI tract. So as long as you have integrity of the gut barrier, you've got the mucus lining, you got plenty of IgA around, your epithelial cells are good, and the cells in the lamina propria are behaving properly, it's a symbiotic relationship. But when you have primary immune deficiency, you lose that symbiosis, and suddenly commensals that are normally friends become foes. And that can be problematic and set off an inflammatory storm. So this is a fairly simple diagram, but it gives you an idea of what we're thinking about. Lastly, should we be giving patients probiotics? So patients with primary immune deficiencies do have a dysbiosis. Patients with COVID-19 have a dysbiosis. And it is difficult because we don't know what probiotics to tell you to take, because some of them may be helpful and some of them may be harmful. I tend to be more of a prebiotic fan than a probiotic fan. I'm not saying that this may not happen, because it may happen, but this is still a shifting landscape and evolving. I am more than happy to take questions. I thank you all for taking the time to attend this session.
Thank you so much, Dr. Clark. We are now ready for the Q&A portion. Please enter questions in the question box. As many questions as possible will be answered. The first question, I believe that serotonin is produced in the digestive tract. Can the manifestations of CVID on the GI tract reduce serotonin levels? And if so, is there anything that we can do to improve our GI health and increase serotonin levels?
That's a complicated question. It's a good question though. So I think in many diseases that are associated with inflammation or autoimmunity, like primary immune deficiencies, serotonin levels can drop. And there's a variety of reasons for that, but definitely the gut-brain axis is involved. The easiest answer to that is being on an SSRI, going on. It doesn't mean you're going to need it forever. You may need it temporarily. So things like, and I'm going to use the brand name just for the sake of this audience to make it easier. Things like Zoloft and Celexa and Prozac are all SSRIs that can help improve serotonin. And again, a lot of times it's just related to the fact that your body's been stressed and you use up those serotonin supplies. There are gastrointestinal malignancies where you can see increased serotonin production, but that's kind of outside of the scope of this talk.
Thank you. Next question, are probiotics safe to take if you have CVID?
I don't think they're harmful. I do think that sometimes people get more bloating with them because you already have an ongoing dysbiosis. So the most common complaint I get with people on probiotics is bloating. And so because we don't know which probiotic to tell you to take, it may make you more symptomatic. That's the answer to my question. I don't think it will hurt you though.
Okay, the next question. My GI doctor says CVID does not affect my GI despite me having nausea and diarrhea every day for 30 years. How can I find a doctor with interest and belief in CVID and GI issues?
So what I'd recommend is most physicians who treat inflammatory bowel disease are well poised to treat primary immune deficiency related gut enteropathies. And so I would suggest that you find an academic medical center in your region where they have a larger inflammatory bowel disease practice, because they'll be more open to treating that.
Great, thank you. The next question, I have CVID and am unable to digest fat. In addition to discomfort when eating fatty foods, I also struggle with low levels of fat-soluble vitamins. Is there anything that can be done to prevent or improve this situation?
So in one of my slides, I mentioned fecal elastase. So it is not uncommon. There's a relationship between the small intestine and the pancreas. And there's a hormone trigger that happens. And whenever that is disrupted, you can get what we call secondary pancreatic exocrine insufficiency. So the pancreas doesn't make the enzymes that you need to digest your food. So getting a fecal elastase would be super helpful for that, because your doctor may be able to add, stop. Sorry, my kids are in the background. You know how it goes. You tell them to be quiet and they don't. You may be able to add a pancreatic enzyme supplement if that level is extremely low. The other thing, as far as fat-soluble vitamins, those can be replaced orally. Sometimes you need to give higher doses and sometimes it takes longer. Let's just take the example of vitamin D. So A, D, E, and K are all fat-soluble vitamins. And so sometimes you need to give a little bit higher doses. A, you got to be a little careful with. E, you got to be a little careful with. Vitamin D, typically in my crowd, I'll treat for up to 6 months just to get that under control. The other thing that if you're really having a hard time with fat-soluble vitamins, there are vitamin patches that have been developed for people that have had bariatric surgery, which by definition is a malabsorptive state. And you can purchase those. Actually, you can get, and I have no financial relationship with Amazon, but they can be purchased on Amazon.
Okay.
And then B12 is often given via an injection anyway.
Okay, thank you. The next question, current research in small intestinal bacterial overgrowth, or SIBO, indicates that having an immune deficiency increases the risk of this.
Absolutely. There's no doubt.
Why is this the case? And is there anything that can be done to reduce the number of SIBO occurrences? Could it be related? I'm sorry.
Oh, I apologize. Go ahead.
That's okay. One more part to the question. Could it be related to issues with the migrating motor complex in individuals with PI?
That's actually a great question. So there's two parts. Well, there's actually several parts to this question. Number one second, because my daughter has decided to get on the, I'm going to just, 1 second. Cammy, you have to get off of there. Cammy, get off. I can't hear on my thing. You have to get off of there. What happens when you have 4 children and they decide that they're going to, thank you guys for being gracious. So let's start with the migrating motor complexes. It is not uncommon when you have gut inflammation to have an impact on the enteric nervous system. And I do see a fair amount of dysmotility that occurs in the setting of inflammatory bowel disease and gut inflammation related to PIDDs. Whenever you don't move stuff through correctly, bacteria that would normally stay in the colon can get up in the small intestine, and by definition, that could cause SIBO. The second part of that question is prevention. So there are, you have gut barrier dysfunction by definition in primary immune deficiencies, whether you have CVID, whether you have IgA deficiency, whether you have some other T or B cell defect. I am, and this is me with my Dr. Glover hat on, I am kind of a fan of using some of these prebiotics, these IgG prebiotics. I think they are helpful. They're not expensive, they're not harmful, and I find that they do help reduce the incidence of SIBO. The other thing that happens is sometimes people just need periodic antibiotics, and you can cycle them. So Xifaxan or Rifaximin is the generic name. Can be used very safely, and you can cycle it. So maybe quarterly you need to be treated with that. Occasionally people will need Rifaximin and neomycin to control small bowel bacterial overgrowth, but it's very individualized. It's not, there's no such thing as one size fits all. I would also recommend that you could consider adding glutamine to your diet. I usually start with 5,000 milligrams a day. I know Josh Milner and some of the folks at the NIH had started working on this project, and it's still very much in the works, but I do like to use glutamine sometimes, and it's not harmful. It's a pretty safe amino acid, and you can get that over the counter.
Great, thank you. The next question, a provider expressed concern about the occasional use of antacids and the impact on immune function, including an increased risk of certain kinds of bacterial infections. Can you speak to this?
Yes, so there is data on PPI's increasing risk of C. difficile infection, so that's a real thing. We also know, and this is a paper that I have out in review right now, we do know in certain ethnicities there's an increased risk for COVID infections in people on PPIs. And again, this is my own prospective immunology study that's out there. So those are real things, but I'm kind of a big believer in everything in moderation. So what I tell my patients is if you need a PPI, you don't necessarily have, we used to say that people had to take their PPI every day, but I think if you're having issues with acid reflux, if you can either switch to an H2 blocker or use your PPI as you need it, that's helpful. If you have Barrett's esophagus, if you've had recurrent erosive esophagitis, if you've had a GI bleed due to gastric ulcers, you kind of need to take your PPI. But in other things where it's less, less ominous if you don't take it, I'd recommend just take it as you need it or switch to an H2 blocker.
Okay. Our next question here. The patient previously had colitis issues in the late teens, but now has more just IBS constipation. Do you see these issues in PI patients?
Yeah, that can happen. I'm still, when I see this, it's interesting because sometimes my, even my, run-of-the-mill IBD patients, once I get their inflammation under control, it's almost like the GI tract doesn't know what to do. It never recovers from, and this is just me explaining it in a really simple way. But I have seen that constipation does happen. It's almost like you never recover. You've had so much diarrhea over the years that you can't swing the other way once things are under control. And I think in that case, what I usually recommend is getting on a really good bowel regimen, whether that's a high fiber Miralax colase regimen, or you need one of the newer agents like Amatiza, Linzess, Trulance. And again, no financial relationships. It's just easier to give you the brand names. But there are lots of options for people that have significant dysmotility. There are some newer agents on the market that can help with motility, both in the upper and the lower GI tract. And you can talk to your gastroenterologist about those. The other thing that I'd like to mention, and this happens more in women, although it can happen in men, there's a fair amount of pelvic floor dysfunction that can happen where you just can't get the poop out. And there are options for treatment of that, including pelvic floor physical therapy. So there's a variety of things that can be done to treat constipation. So don't despair.
We have a few more minutes here. The next question, can CVID cause autoimmune pancreatitis?
Absolutely. And I forgot to mention that one. I was thinking about that while I was giving that slide. Yes, it can. Yeah.
Okay.
I would gather that it's more, there's two types of autoimmune pancreatitis, type 1 and type 2. I would guess that it's more type 2, although again, that's where it's kind of important to get some biopsies. You can do biopsies of the ampulla, which is the little entrance to the pancreatic duct, and you can look for IgG4 stains, and it does change management. Oftentimes with autoimmune pancreatitis, you're going to need some kind of immunomodulation, and in certain individuals, you may even need rituximab. So,
okay. I think this is going to be our last question. Does getting IVIG versus subcutaneous put you at a higher risk for developing liver or biliary disease?
Not that I'm aware of. Not that I know of. Yeah. No. Not that I know of. Yeah.
Okay, we'll take one more. Does age of a person with PI affect the risk of GI issues or the liver?
That's okay. So as people age, their immune system tends to be more senescent, so it quiets down. So if you develop primary immune deficiencies earlier, you are more likely to have, there can be a more robust GI response. We see this in inflammatory bowel disease. So people who develop inflammatory bowel disease earlier on tend to have worse disease than people who develop it later in life. It's a lot easier to treat a 60-year-old with bad, with gut inflammation than it is to treat a 10-year-old. And that's just experiential, but I think the data does support that.
Okay. Are PI, particularly CVID patients, at higher risk for cancer with eosinophilic esophagitis?
The answer to that is we probably don't know. So eosinophilic esophagitis is an inflammatory condition. It's a chronic inflammatory condition of the esophagus. It does increase fibrosis. I have not yet seen any esophageal cancers related to that. However, the data, this is a disease that we really didn't know about until the early 90s. So, and we've been pretty aggressive about treating it. So the answer is that the jury is probably still out.
Okay, our time unfortunately has come to an end. Please join me in thanking Dr. Glover for joining us today. Thank you for sharing your knowledge and your expertise. We truly appreciate it.
And thank you for having me. I enjoyed it. And I apologize for the kids in the background. So, all right, take care, guys.
Have a great day.